Good afternoon, colleague. Welcome to ISSUP webinar, The Implication of COVID-19 for Mental Health and Substance Use. I am Eva Suryani from Atmajaya Catholic University of Indonesia, and we have three speakers, one from India and two from Indonesia. And for the first speaker, I would like to introduce Dr. Arun Kandasamy, MBBS. He is an additional professor of psychiatry, Center for Addiction Medicine, National Institute of Mental Health and Neuroscience, Bangalore. And he would like to present about the influence of quarantine restriction on mental health and substance use. I would like to give the floor is yours, Dr. Arun. You're still mute.
Thank you very much, Priva. At the outset, I would like to thank the organizers from ISSUP for inviting me to make this presentation. Today, I'm going to present on the influence of quarantine restriction on mental health and substance use disorder. This is the Department of Psychiatry at NIMHANS, Bangalore. This is my alma mater, and I would like to start with a certain disclaimer that my presentation is not going to be restricted to quarantine alone, because it was very difficult to find data around that only. And it's not going to cover very important group, that's the frontline workers per se, but that itself will become one full seminar and full day work. The quality and consistency of the fact in the published literature regarding this issue, they are not methodologically sound. So we really, there are a lot of opinion pieces which have been written, which is not backed up by the data also. And the data which had come are from certain regions specifically. So each region had their own issues in terms of the regulations and how the health system is. It was very different, and the intensity of the COVID itself was very different across the regions. So the generalization to the whole population and the whole world may not be possible. So with this intro, I will move on to, and also that it's going to be an overview. So I will cover many of the areas in small bits and pieces. Maybe we can discuss if there are any areas which needs to be covered. So I would like to make this presentation into a bit of introduction, and then the common mental health issues which is found in this group, and then specifically the special populations, and also concerning the issues of the vulnerable people, the psychiatrically ill, and people who are with addiction and related problems. Now, we all know about the global effect of COVID-19. The most important part of is what Louis Pasteur had talked about. The role of infinitely small in nature is infinitely large. So the microorganisms which are playing an integral part of our ecosystem, how it can influence the health and well-being of people, plants, and animals has been demonstrated very, very, very well during this period as such. And you can see the global effects ranging from the food security for people as such, and how the healthcare system is burdened with communicable diseases, and many of the health systems getting broken down, and how mental health issues happens with people, how the industries have got affected, the tourism industry has got affected, hospitality industry has got affected. Education sector has taken a big hit because of the offline classes have been cancelled and moved towards the majority towards the online classes, and aviation industry is completely shut down for a very, very long time. The sports and leisure activities are completely gone. Mortality arising out of COVID related issues has and generally the mortality has increased over a period of time. There is an interesting situation in terms of the environment pollution coming down was noted in this period because of all the above said reasons. Like, so the global effect of COVID-19 has been quite intensive in all sectors of our life as such. So COVID-19 was considered as a medical disorder, communicable disease as such, like. But it's not only a medical disaster because of the nature of the onset, the sudden onset of it, and the unpredictable nature of how the symptoms one is going to get. Because some people, to start with, only elderly people were affected, but then the different waves had different kinds of effect on people. Younger people also affected, and then mortality in younger people also noted. Initially, people with non-communicable disease comorbidity has been found to be having problems, but then it eventually changed over to others to having a major problem. So there's an unpredictability around the whole illnesses, and there's no control which people can have in various areas, like the spread or how their own life can be controlled on a day-to-day basis. That's uncontrollability. And the huge magnitude of destruction which has happened because of the COVID-19, human loss and suffering, human suffering, which has come up, and all these things have greatly exceeded the inner coping mechanism which the individual has, the family has, and the community at large. Usually, it's the individual or the family, but then here even the coping mechanism of the community itself and the global community itself has affected significantly. COVID-19 is also a mental health pandemic as such, right? Because there is widespread panic, stress and anxiety among the public which has been there, and this is fueled by the rapidity at which the pandemic spread, unlike the previous times, and the uncertainty about its course itself. Many people didn't know how the course is going to be, because we had seen at least twice the waves hitting in India, where there's a lot of uncertainty about how things are going to go, and the duration of restrictive measures in terms of lockdown, social distancing, prohibition of substances, in very various things, like, and the duration of restrictive measures, because some places even the health systems had to be shut down because of the overload, and there are certain parts of health system need to be shut down, and so that the communicable disease can be taken care of. There's a lot of say uncertainty had come up. Like misinformation is another thing. Like there are a lot of things which have been spread about the origin, how the impact is, and a lot more, where we really didn't know about it, but there are a lot of misinformation which had come in, and that resulted in a huge problem of migrants moving around the country, and then a lot of issues in terms of how the spreads can affect one another without much knowledge. These things resulted in chaos. And there are also mistrust towards frontline workers happen because of these misinformation, and there are a lot of stigma against health workers itself has happened in the country, in our country also, so that the government has to take steps towards people who are creating this kind of stigma. And there's a worry about special population, especially the elderly and the younger one, children and the pregnant women per se. So moving into the common mental concerns which are there in this area, fear and worry about acquiring the disease itself was there. And because there is a possibility of acquiring the illness if one goes to the health system, either for treatment of some chronic medical illness which they were there, the non-communicable disease, or any form of medical illness, or some new medical illness which comes up. So because fear of contracting COVID, the approach to these health facilities had come down, that resulted in significant amount of distress. And there is always a concern about how the general health of the person, him or herself or themselves, and the beloved also, because there was no control and no movement could be possible. So the beloveds were there in some other place, and how we were all frustrated about that part of it, and this caused distress. Changes in sleep and food habits in a lot of time spent in front of monitor and screens, and eating because there's nothing else available, so the eating habits have changed. The worsening of current medical conditions which were there, or the newer medical conditions, have become a major issue. Increase of substance use has been noted in certain population. The loss of livelihood, many people have loss of livelihood, and the fear of losing the livelihood also is the common mental health concern, and not able to go to work, social isolation, and fear of being quarantined if contracted the state, that result in a lot of mental health concerns, panic and anxiety. Fearing of the powerlessness in terms of protecting one's own loved ones because they are not around and they couldn't help them out fully, and the fear of being separated from being loved ones because of quarantine or the lockdown as such. Like this, a rampant helplessness and hopelessness had been there over here. Post-traumatic disorders and depression had increased in this thing. Dr. Christina would be talking in detail about it. And there's a constant exposure to the media where disturbing images and the statistics has been ratified again and again. That has caused a lot of issues. And also the common symptoms are very common, which happened always, and that has caused worries whether it is COVID or not. And children staying at home without much things to do, that has increased the distress. Anger and irritability towards government agencies because there doesn't seem to be a swift action, because they were also not able to do much because of the uncertainty in the community at large. And also the worsening of pre-existing mental problems happened. Like, along with all these things, boredom and loneliness had become a major issue for many because they have been completely cut down of contacts. No kind of socialization was possible. That resulted in a lot of mental concerns arising out of this particular thing of boredom and loneliness. This is data which had the telephonic services which we conducted in NIMHANS, where we could sense that the source of distress, many people called with distress, there were distress calls, boredom and social isolation, economic and work-related stresses, fear of infection and tests and delay in results regarding results, concern of spreading infection to family, and the stigma associated with it. These all are the source of distress with which people had made the calls. And the assessment showed almost around 13% of them had anxiety symptoms, 4% had depressive symptoms, sleep disturbance were there in almost 5%, and suicidal ideations were there in 2% of them. In the special population, elderly needs a special mention because they were found to be the highest risk of morbidity and mortality with this infection because of low immunity power and a lot of changes within the elderly group. The source of distress were their separation from family and other loved ones, and loss of loved ones in terms of relatives and friends that happened around them, just put a lot of stress over themselves. Social isolation was always a part, and here it has worsened. And they had pre-existing health conditions which couldn't be treated properly because of the restriction of movement, also non-availability of services at different times, and the fear of contracting infection if they end up in any kind of health setting. In children, it's a very, very important issue because they were always at home and they are being always in front of the monitor. They don't have any kind of social interaction. And at different age group, different problems. For example, the people who are at age of 3 to 5, those who are the toddlers, they had problem about they couldn't start the schooling itself. So obviously the stimulation school environment which can bring to them and that improving their communication skill, all those things had affected. Those who are more prone for anxiety and poor communication skills, this has become even more an issue because they were not able to learn the skill of able to communicate with people and move forward with things, and all the time be sitting in front of computer had made them to move towards gaming and other issues, which had become a perpetual problem per se. And the children were not able to go for any kind of, their energy couldn't be spent on any physical ways. So that pent up energy also caused trouble at home in terms of anger and irritability, anxiety, fear, worry, confusion, depression, difficulty in sleeping, and loss of appetite. And in terms of COVID positive children, it was another level of problem, because they were very irritable and will not be willing to follow the PPE kit things, and their care is always compromised in that. Caregivers had a major problem, and so overwhelmed responsibility and because of the responsibilities, and they were overburdened because the lack of health and resources around them. Like they started feeling sad, stressed, confused, scared, and angry during this crisis. A lot of exhaustion and frustration was able to be seen. And there was also a lack of personal space for people, because all the time they are within that space itself. That had resulted in a different level of problems in terms of increasing intimate partner violence and domestic violence also. Time management had become a major problem. People with previous mental illness and they when in this situation, obviously the severe mental illness, people who have severe mental illness also are affected, because their need for long-term and continued medical management got affected, because they were mostly dependent on the government services, which had to shift their resources towards treating COVID-19 patients. And there was a very high risk of relapse due to medication discontinuation. And also this became another burden to the mental health system. Right? Substance use disorder, again, the data says up and down about various things. Some studies say that increased substance use disorder, some studies say decreased substance use disorder. This is a tier system where what happened, what is being explained is those who belong to the tier of high intensity substance use related problems, in terms of those who have comorbid mental health problems and significant amount of dysfunction because of substance use itself prior to the onset of COVID, they seem to be affected significantly. The tier 4 and 5 had increased substance use during the pandemic. Alcohol, during lockdown, there are non-availability of alcohol, which resulted in the alcohol withdrawals, complicated alcohol withdrawals. This is a communication which we published in Alcohol and Alcoholism, because during the lockdown period, we had an exodus of people coming with complicated alcohol withdrawal state in terms of seizures and delirium because of non-availability of alcohol. Our acute emergency services started with people with complicated withdrawal. In opioid substitution treatment, people with opioid dependence, we found that since we follow home-based opioid substitution, many of them couldn't come to the system to collect their medication and go back. So many of them had to be weaned off the medicine, and that resulted in problems. Some had landed up in using the substance itself. Some had found it very, very difficult to manage. In fact, the impact is still felt, because 23% of patients who are on regular OST are not seemingly coming back to the system. This is a recent assessment which we have audited within ourselves. Once immediately the prohibition was lifted, there is a huge number of patients who with relapses who have been maintaining very well for a long period of time had started coming in. There was increased alcohol use, violence in terms of there's a poor resource which are available. So see, there are violence which happen inside house, and stealing away money from the home. A lot of things happen, and there are reports of fatal overdose also had increased. Behavioral addiction had increased significantly in terms of gaming and gambling. And in fact, one of the reports says the first time online poker players increased by 255% since the stay-at-home order began. Like, I see inappropriate usage of food as a coping strategy has been noted. During pregnancy and postpartum, entirely different story, where I will get delivered, who will be there with me, will I get COVID or not. There's a huge amount of mental stress, and I have One of my niece was delivered during that time, so I know what my sister-in-law went through, and I'm first-hand saying. Suicidality has significantly increased. The people with substance use disorder has also had significant suicidality seen in this thing. This is because of the uncertainty over the future and also the pre-existing psychological issues with their life. So those who with excess stress, those who are facing isolation, helplessness, or hopelessness, those who are anxious and agitated, and those who had suicidal plans, and like they were at a high risk of suicidality. Aggression is also noted in various population, especially those who are there in quarantine facilities and shelters, and also has substance use disorder and major mental illness. Their aggression was known in seen in them also. Psychotropic drugs, interaction between drugs were also a problem. But the most important problem, the elephant in the room, was that there's no access to medication or services for severe mental illness, which happened for a particular period of time, because people were not able to travel to their health system and take medications, because this became not the priority as such, like, and that resulted in a lot of relapses as such. These are the manuals which we have created during this period of time for the access to the professionals, and I think if you click on this link, you will get the manuals which were there in the NIMHANS official source. To summarize, there are quite a lot of stressors around the COVID-19 issue itself has happened, right from restriction and long lockdown and social distancing, and the rumors which are happening around risk of relapse because of the pre-existing conditions and confusion about common health symptoms, and the physical isolation and quarantine. There are a lot of issues which has happened. So this is a big example of Louis Pasteur when he said, like, the role of infinitely small and then nature is infinitely great or large. I acknowledge Dr. Naveen Kumar, who is a professor and head of the community psychiatric services, for providing some of the data. And a big salute to all the corona warriors who would contribute significantly in helping out the situation. Thank you very much.
Thank you very much, Dr. Arun, for your wonderful presentation. And now I would like to introduce the second speaker, Dr. Christiana Siste. She is psychiatrist from Faculty of Medicine, Universitas Indonesia, and she is the head of psychiatric department at Cipto Mangunkusumo General Hospital, and also she is the head division of addiction psychiatrics. She had been many awarded fellowship, and apart from clinical and academic work, Dr. Siste also strives for community health and mental well-being. So Dr. Christiana will present COVID-19 and risk factor of mental health problem. Dr. Christiana, please can present now. Thank you.
Yeah, thank you, Dr. Eva. So good afternoon, colleagues. Thank you so much for ISSUP International and also ISSUP Indonesia for this opportunity. So I would like to share about COVID-19 and risk factor of mental health problem. Okay, so the first part, I would like to share about how the COVID-19 pandemic affected individuals' mental health. And at first, I would like to share about the data of COVID-19 in Indonesia. But first, this is the data from Southeast Asia in 2021, and there are around 45,000 confirmed cases. And then we see here several countries has third wave of COVID-19 pandemic. It's happened in March until July 2021. And also in Indonesia, we have a second wave, I'm sorry, not third wave, but second wave of COVID-19 pandemic also happened in Indonesia around July 2021. And we have many cases in second wave, and also many death cases at that time, and lack of health facility in our country. And Now, this is the data, the updated data from our country in 2021. We have around 4,000 coronavirus cases, and we can see here we also have around maybe 80% recovery cases and 143 death cases in 2021 until 2021, and of course faces second wave in this year. Our country, our government, we think that already have a regulation and also strategy to face the second wave of COVID-19 pandemic, and it's better than the first wave of COVID-19 pandemic. And also our government has done many vaccinated activity for the people in our country. And to face the third wave of COVID-19 pandemic, so our government also have a new regulation. It's like in the first wave of COVID-19 pandemic, our government has semi-lockdown regulation in middle of this December. And also, in the early beginning of COVID-19 pandemic, our government applied a large-scale social restriction and limited public mobility. And but at that time, National Narcotic Board found that there is drug seizure remain high at that time. And in the early of pandemic of COVID-19, there was rampant hoax on alcohol consumption killing the coronavirus, and that at that time the unrecorded or a counterfeit mixture of alcohol drinking were not affected by the large-scale social restriction. But at that time, there was education on significant association between smoking and severe cases of COVID-19. And also, like Dr. Arun has already explained, we know that there is correlation between mental health problems and COVID-19 pandemic. This data from meta-analysis from 31 studies, and this data show us among general population globally, so the prevalence of depression during this pandemic is around 45%, and also anxiety around 47%, and also there is sleeping disturbances during this pandemic around 17%. And how about among health workers? And this is the data from nationwide based study in China. So the prevalence of depression among health workers is quite high, around 50%. And also, for the prevalence of anxiety is quite high, around 45%, and also 34% of health workers have insomnia. And also, the mental health problems cause distress among health workers in globally. And how about the mental health problems of the confirmed COVID-19 patient? So if the patient with COVID-19, so the mental health problems will increase around 1.5 until 2% compared to the people without COVID-19 infection. And also the patient with COVID-19 infection tend to have mental health problem like depression, and also it's around 30 until 45%, and also sleep disturbances and feel fatigue all day, and also decreased mental health status and anxiety disorder around 47%, and also they can have post-traumatic stress disorder and feel confused around 65%, and feel agitated around 70%. And also, they tend to have memory impairment around 35%. Although if they have recovered from COVID-19 infection. And this slide shows us why there is significant correlation between COVID-19 infection and a mental health problem. Because lack of infection disease knowledge made people feel anxiety and depressed about the uncertain situation. And then lack of health behaviors, and also lack of physical and mental health knowledge, and also sometimes they lack of mental health assessment and self-judgment methods, and also lack of psychological coping methods, because many people has to decrease the stress with go out with the friends or other people.
Okay.
Hi there. We've just lost the connection of the moderator, Eva, and the presenter, Dr. Sister. Hopefully they will be able to rejoin the webinar shortly, but we appreciate your patience and understanding as we just wait for them to reconnect. Hopefully we'll give them a few minutes and they'll be able to rejoin. If not, we'll move on to the next speaker. Thank you so much. Dr. Sister, are you there? We can see you and we can see your presentation, but we can't hear you at the moment.
Okay.
Now we can hear you. Now we can hear you.
So you can hear me, Olivia?
Yes, we can.
And I think this is my last slide. I mean,
Okay.
I disconnected. Okay. So
Yes.
yeah, I will continue. Sorry for the technical problems. Okay, so this slide shows us the significant relationship between the mental health problem and COVID-19 pandemic, and there are many risk factors for mental health problems during this pandemic. This data show us the comparison data of for global data of mental health problem, and also Indonesia data. So the data from Indonesia is quite high for anxiety, depression, and also psychological traumatic. And in the early beginning of COVID-19 pandemic, we have a survey, and there are around 4,000 participants at that time, and around 65% of them have mental health problem, and around 62% of them have a depression, and 65% of them have anxiety, and 75% of them have psychological trauma. And I will switch to substance use disorder because substance use disorder also tend to increase during this COVID-19 pandemic. There are many research about substance use disorder during the pandemic from several countries. And why a substance use or substance addiction is increasing during this COVID-19 pandemic? We know that lockdown policy and isolation makes some anxiety and also depressed for some people, and also there are financial problems, so it can make a new onset psychopathology like depression and anxiety. And many people, some people have a coping mechanism to use a substance to decrease the stress or the depression or anxiety. And then there is also reduced availability of health workers in addiction clinics. So the people with a substance use, they cannot go to the clinic during this pandemic because of a semi-lockdown or lockdown. And also there is reduced drug availability. So the person with substance addiction, they feel it's very difficult to access the health facility. And also among this pandemic, there is also a risk factor for cross addiction. So maybe the person has addiction to one drugs, and then because it's very difficult to get during this pandemic, so he will change the drugs to other drugs. For example, we found that many people change to alcohol during this pandemic. And also, so there is increasing substance addiction or substance use cases during this pandemic. And I would like to share about the substance addiction data during this pandemic in Indonesia. So we already published the research in early 2021, and this is online survey from April until June 2020, and we have participants, around 7,000 participants from 34 provinces in Indonesia. So this is national data. And this slide shows us the prevalence of substance use during COVID-19. So the red one is total participant, and the yellow one is adolescents. So the prevalence of cigarette use among adolescents is around 3%, and alcohol use among adolescents is around 5%, and drug use among adolescents is around 0.5%. So I think we think that this is a significant problem during this COVID-19 pandemic, and we will focus on adolescent because it needs a very intensive and massive treatment for adolescents who use drug or alcohol or cigarette. And during this pandemic, you can see here for alcohol consumption among adolescents, around 40% of them unchanged behavior to consume to use the alcohol. And for cigarette, for alcohol we can also see here around 31% increase of alcohol consumption during this pandemic among adolescents. And but cigarette, so the dominant is around 33% decrease to use cigarette among adolescents during this pandemic. And how about drugs? Around 50% unchanged the drugs consumption during this pandemic, and around 30% increase the drug consumption during this pandemic. And this is the perceived drug use among adolescents in our country. The prevalence is quite similar before and during COVID-19. It's around 0.4%. And we can see here, most of adolescents use other drugs like prescription drug like tramadol and also benzodiazepine, and they can get it by illegally or by online. And this is the characteristic of adolescents who use drugs during this COVID-19 pandemic. Around 85% are female, and they are mostly late adolescents, 17 until 19 years old, and 30% of them use polydrug, not just one drug, but more than 2 drugs. And we can see here for drug use, many of them unchanged the behavior about using a drug during COVID-19 pandemic, and around 30% increase using drug during this pandemic. And how about alcohol consumption? We can see here the prevalence is increasing compared to before COVID-19 pandemic. The prevalence become 5.1% during COVID-19 pandemic. And the risk factor, if they have higher education level, and if they don't have employee training, and if they have higher audit score and very low prosocial behavior. And for adolescents who increase the alcohol consumption, mostly are late adolescents, 17 until 19 years old, and from low household income. And how about the cigarette consumption among adolescents during this COVID-19 pandemic? So the prevalence is decreasing during COVID-19 pandemic. And most of them are male, and they are from late adolescent. And the prevalence from 18% before COVID-19 become 3% during COVID-19 pandemic. And the risk factor are male, increasing age, and higher CDS score. Cigarette, it's like the questionnaire to assess the cigarette addiction. And we can see here 44% of them decrease the consumption cigarette during this COVID-19 pandemic, but most of them has lower sleep quality and higher emotional symptom and lower prosocial behavior. And this is my last part of presentation, and how the challenges and strategies of substance use disorder services during the pandemic. So mental health problems patient and also substance use patient will face high stigma in environment. So it should be adaptation in psychiatric services due to pandemic to reduce the stigma toward people with substance use disorder. And it will involve the policymaker, healthcare providers, and other key stakeholders for planning and coordination. And also many literature suggests to integrate additional services with other health services to reduce the stigma for the people with substance use disorder. And we need to do campaign by mass media on television or the internet to encourage the people with mental health problem and substance use disorder come to the health provider to get the treatment. And also we need to recognize the role of caregiver or relative of people with substance use disorder, with do the training for them, how to communicate with the patient and how to handle the patient. And this data from 17 countries about adaptation in psychiatric services due to pandemic, and the problem is a reduction in the availability of services and increased reliance on telemedicine, physical distancing protocol, and travel restriction. So many countries have such dysregulation, like increase of take-home dose of opioid agonist maintenance treatment, and increased duration of take-home dose of in the primary healthcare or in the hospital, and increase the availability of naloxone and injecting equipment allocation and shifting to online services. And this is the adaptation addiction services in our country. So we apply physical distancing and protective equipments, and also we use telemedicine for the patient and the family, and we use screening and reduce inpatient capacity in hospital by 50%, but now is quite we add the capacity more than 50% now, and transition of training to online platforms. And also we try to do research about the effectivity of telemedicine for the people with substance use. So this is the module we adapt from Japan to prevent the relapse. And from this research, the participant feel more comfortable to have online or teleconsult treatment, so they can join from home, so it's more convenient and transportation time or cost, and also they feel frustrated with technical issue like what happened to me now today, and also they feel that they can open up personal matter to counselor by teleconsult. So it doesn't matter if they have teleconsult, because they have opened up the personal matter in the counseling. And then this is the data that we got from the pilot test. So this module increasing psychological health in participant with telemedicine module compared with therapy as usual. Therapy as usual, the participant come to the clinic like before COVID-19. And also this module decreasing the number of day using primary drugs compared to therapy as usual. And also this module have higher motivation outcome compared to the therapy as usual participants. So from this data, we can see that telemedicine module for relapse prevention is has the good or better outcome from therapy as usual, and 75% of them prefer online than face-to-face meeting. And also we developed the internet-based intervention. It's called Inspire. So the people with substance use, they can access to treatment monitoring, and also the prevention program, and also the program to reduce stress to prevent them to use drugs. So it can be accessed by many by the people in our country. And we use artificial machine learning for this internet-based intervention. And also we should enhance community enforcement, like we use by podcast or online meeting, and also the training for healthcare workers. And this is the my last slide. So for the recommendation, so we need to enhance tailored approach based on empirical evidence, and also progressive national policy and active telemedicine infrastructure, because we need the telemedicine now during this COVID-19 pandemic, and also proactive community education and intensive counseling, and novel or updated universal substance misuse prevention program, especially for adolescents, and also online virtual training and certification. So thank you so much for your attention. Thank you, Dr. Eva.
Thank you so much, Dr. Christiana, for your fruitful, comprehensive presentation. And now the last speaker, I would like to introduce Dr. Elvina Catherine Sahusilawane. She is a psychiatrist from Indonesian National Narcotic Board Drug Rehabilitation Center. She is a medical coordinator, Indonesian National Narcotic Board Drug Rehabilitation Lido, and national trainer universal treatment curriculum, and has 14 years clinical practice in addiction field. And Dr. Elvina will present about COVID-19 and stigma. Dr. Elvina, the time is yours.
Good afternoon and greetings to all the participants, the speakers, and also the organizing committee of these webinars. Thank you for the opportunities given to me to share about COVID-19 and stigma. When we talk about COVID-19, the pandemic situation has had a lot of consequences, negative consequences to people around the world. And we also know that social distancing is one of effective ways and tools to limit the spread of the coronavirus. But it also have unintended health impacts. Limited social interactions and uncertainty of the pandemics has led to increase the substance use as a way to cope with situations. Confusion, anxiety, and fear among public about this situation has provoked stigma and discrimination to anyone who have been in contact with the virus. And this condition, unfortunately, also reinforced the stigma that has previously existed in the people who use substance. Now let's talk about what stigma is. Stigma is a negative association between a person or group or people who share certain characteristics and a specific disease. Link and Fallon describe stigma as a relationship between an attribute and a stereotype that assigns undesirable labels, quality, and behaviors to a person. People who are perceived to be different are often labeled, for example, as a drug addict or COVID case. Society tends to have stereotypes that go with this label. And this is a particular view of what such person is like. In the case of SUD, they are dangerous, unreliable, and unable to make decisions. When such stereotype is attached, then a person is reduced to the stereotypes and people tend no longer to see the actual human being. Stigma can take on a various phases. It may be very subtle and it usually happens in the early stage. For instance, people start asking questions about the illness or look at them as suspiciously and also make insensitive remarks like he must done something wrong to deserve it. At the other end of the spectrum is overt negative behavior called discriminations. Discrimination is an act of stigmatization. People are treated separately, treated differently because of their health condition or other differences. And discrimination against people with substance use disorders deprives many individual opportunities like housing, school, or employment. Researchers identified different types of stigma. The first one is public stigma, involves the negative or discriminatory attitudes that others have about the disease. The second one is self-stigma, refers to negative attitudes, including internalized shame that people have about their own conditions. Individuals who have contracted the COVID-19 virus may believe that they did something wrong to get it, maybe not using masks properly or other health protocol. As a result, they may feel loss of self-esteem, feels fear, shame, hopelessness, and guilt. They may accept diminished expectation about themselves and start behaving the way people expect them to behave. At the end, this leads to social exclusion in the same way as discriminations. The third one is institutional stigma. This is a more systemic, involving policies of government and organizations that limit opportunities for people with SUD. For example, lower funding for SUD health services relative to other healthcare. There are several factors that causing stigma, but fear is the most common factors that causing stigma. This may be fear of catching a disease that infectious, just like COVID-19. Fears can lead to stigma among members of the public or among health workers, but it can also among people who are affected with the condition themselves, who may be afraid of infecting loved ones like children or other family members. They may be fear of the social consequences of disclosures of their conditions. Stigma by association is also known as symbolic stigma. This may occur when a health condition is associated with a condition that is perceived to be undesirable. Examples are conditions that are associated with commercial sex work, illicit drug use, sexual orientation, and poverty. One condition may also become more stigmatized because of association with another condition. A very good example is SUD and its association with HIV/AIDS. Value and beliefs play a powerful role in creating or sustaining stigma. Example are beliefs regarding the cause of conditions, such as belief that addiction is a result of moral weakness and flawed characters. Particular cultures may hold particular stereotypes regarding people with certain condition, and this may be conscious or unconsciously. These are the factors that influencing public perceptions and beliefs about a disease. The first one is blame. People with SUD are generally considered to be more responsible for their conditions than people with other mental disorders. Belief that this illness is a result of the person's own behavior can also influence attitude about the value and appropriateness of publicly funded treatment and services. A biogenic model of the origins of SUD has been applied to reduce the blame and promote positive attitudes about the value of treatment, but still there are lack of evidence supporting these efforts. Stereotypes of dangerous and unpredictability are associated with a higher level of public stigma toward people with mental illness. And people with SUD considered even more dangerous than those with schizophrenia or depressions. There are actually some factors increasing the risk of violence, such as people with SUD and co-occurring disorders like SUD with psychotic or SUD with personality disorders. Besides, there are also socio-economic factors like poverty, crime victimizations, early life trauma, or high crime rate in the neighborhood. Next is the knowledge about a disease or disorders can influence the public norms. Healthcare practitioners outside fields of behavioral health also lack of knowledge about mental illness. And there is evidence that this can lead to misdiagnosis of both mental and physical conditions, and also selection of the proper treatment. In one study, nurses' self-reported lack of knowledge was associated with greater reported fear and avoidance of people with mental illness. Conversely, emergency room staff who reported having skill in treating this disorder may have more positive views about the possibility of recovery than those who did not have the skill to treat the mental health conditions. The contact and experience with people with the disease or disorders affect understanding and opinion about the disease in general. Some studies has found that contact with people with SUD raises the level of stigma, But there are also studies that show more positive attitude towards people with SUD after they experience contact with them. Despite these variations in outcomes, there are many evidence suggests there is a strong and consistent inverse relationship between contact as an intervention and the level of stigma. The more contact with people with SUD is associated with lower level of stigma related to these disorders. Last is media portrayals. Media provide idea about an image of behavioral health that influence public attitudes, beliefs, and behavior toward people with mental illness and SUD. Much of evidence on the media influence on the stigma change is in negative directions. The media play important role in stoking fear and intensifying the perceived dangers of person with SUD. However, media can also be platform for prevention by providing positive message about available support and resources. So we can see that COVID-19 and SUD is both facing stigma issues because COVID-19 is a new disease and for which there are still many unknown and people are afraid of the unknown and some people are vulnerable population to face the stigma like people of lower economic status and also people with SUD and racial or ethnic minorities, as they are less able to stay at home, less able to social distance and avoid risk of infections. And SUD, the public perception of SUD, they are unpredictable, dangerous, morally responsible, and they have more problematic stigma issue during the pandemic COVID-19. So what are the impact of people who use substance in these situations? There are some aspects that we can talk in this area. The first one is health. So internalized stigma have been linked to increase in psychological distress, emotional, mental, and physical. So this can lead to poorer quality of life. And for some people, stress, isolations, and uncertainty of the pandemic led to increased substance use to cope with the situation. Social distancing and limited trips to outside the home reduce access to services, such as a support group or outpatient treatment. In the healthcare system, people with SUD may face significant stigmatization by healthcare practitioners who don't have training in caring for people with SUD. They may be at loss as how to interact with someone acting threateningly because of withdrawal or acute intoxications. And this condition can lead into inadequate care for people with SUD and concurrent COVID-19. Stigma on the part of healthcare provider who often see a patient with SUD as their own fault leads to substandard care or even rejecting individuals seeking treatment. The past experience of confronting stigma within the health system or fear of discrimination may discourage patients with SUD to seeking care when symptoms arise. And so stigma can drive people to hide their illness or symptoms to avoid discriminations. So it causes delay in accessing testing, contact tracing, or treatment. In the case of infectious disease like COVID, stigma can complicate the efforts to control the disease. It causes delay in diagnosis and treatment, which may prolong transmissions in the community. Stigma may be also a barrier to preventive behavior. For instance, some people may refuse to come forward for a free screening sessions of COVID-19. So this silence inhibits prevention program. The last is the policy programs intended for managing the SUD. During pandemic, SUD had not featured significantly in policy and program planning in most settings. Hospital-based services were planned and restructured, and addiction wards in some settings have been repurposed into COVID-19 wards, with little future planning regarding to the addiction services. So the health addiction services were reduced to a minimum, and some countries reported that addiction services was provided by general psychiatric services. So substance users were then offered care when required in psychiatric department of hospital. This figure illustrates the relationship among consequences of stigma at various levels and potential target and intervention to reduce stigma at each level. The targets of structural stigma would include legislators, policymakers, employers, healthcare providers, and criminal justice professionals. And the intervention that would be appropriate for this level are legal strategies, policy strategies, advocacy strategies, and professional education. At the level of general public stigma, the target groups based on gender, age, racial, or ethnic groups. And the intervention would be media mass messaging, educations, community programming, and contact strategies. And at the level of people with behavioral, the level of self-stigma, the target will be people with behavioral disorders. And the intervention that would be appropriate is education, empowerment strategies, and peer support. So what can we do as individuals to reducing the stigma? We can talk openly about mental health, such as sharing on social media. We can educate ourselves and others, respond to misperception or negative comments by sharing facts and experience. Be conscious of language because words matter and reminds that to people. Encourage equality between physical and mental illness. We can draw comparison to how they would treat someone with other chronic disease like cancer or diabetes. Show compassion for those with mental illness. Be honest about treatment. Normalizing mental health treatment just like other healthcare treatment. Let the media know when they are using stigmatizing language, presenting stories of mental illness in a stigmatizing way. And last is choose empowerment over shame. I think we can all start from ourselves to reduce the stigma. Yes, and I think this is my last slide. Thank you for your attention.
Okay, thank you, Dr. Elvina, for your wonderful presentations. I would like to apologize because the limitation of time, we didn't have time for Q&A. But if you have any question or comment, you can send email to info@issup.net or engage in discussion on the network on the ISSUP website. To close this webinar, I would like to say thank you so much for Dr. Arun, Dr. Sister, Dr. Elvina for your wonderful presentation, and the committee and everyone who attend this webinar. See you next time in the ISSUP webinar.
Thank you, Dr. Eva.
Thank you, Dr.
Thank you. Bye-bye.
Thank you.
Very much. Thank you all.
Thank you.